A very good evening to one and all. On behalf of Indian Dental Association Hisar branch, I, Dr. Bhuvan Nagpal, Joint Secretary, extend a very warm welcome to all the esteemed participants joining us today. It is indeed a privilege to host the first session of IDA Hisar Webinar Series 2026, organized on the occasion of World Oral Health Day. A very happy World Oral Health Day to all the participants here. Today's topic, management of medical emergencies in dental clinic, is extremely significant in ensuring patient safety and preparedness in routine dental practice. Such knowledge is not only clinically essential but also professionally and ethically indispensable. It is now my honor to introduce our distinguished speaker for this session, Dr. Nageshwar Iyer sir. Dr. Iyer sir is a highly respected oral and maxillofacial surgeon, an eminent academician, and an innovator in the field. A university topper with 7 gold medals, he has made remarkable contributions to the clinical practice, teaching, and research. He has served as Dean and Principal of Maharishi Markandeshwar College of Dental Sciences and Research and has been honored with the Lifetime Achievement Award by AMSI Haryana. His scientific contributions include the well recognized comma incision technique for third molar surgery, along with numerous national and international publications. With vast experience and deep expertise in maxillofacial surgery, trauma care, and clinical education, Dr. Iyer sir continues to inspire and guide the dental fraternity. We are truly fortunate to have him with us today. I request everyone to actively participate and make the most of this academic session. With this, I warmly welcome and invite Dr. Nageshwar Iyer sir to begin his lecture. Thank you. Over to you, sir.
Yeah, good evening, everybody. Good evening, Bhuvan. And it's indeed a pleasure to be with a very august gathering in the form of IDA Hisar branch. And it's a pleasure meeting so many of my students and my acquaintances there. It's really a big thing for me because I had plans to visit Hisar several times, but somehow or the other I couldn't personally come there for such a long time. And this has given me a platform to meet everybody there. Thanks a lot, first of all. So my topic is management of medical emergencies. I hope I'm audible
Yes,
to
sir, you
everybody.
are audible.
Uh, my topic is management of medical emergencies in dental clinic. Got stuck somewhere.
I think, sir, you can reshare this one, sir.
Yeah, that's
Once
right. I mean,
disconnect and
nothing is going on. It's not even disconnecting. That's the problem.
okay. I'll let me.
I'll leave the meeting and join in again, I think.
Okay. Can you stop
Uh,
sharing one, sir?
Yeah, I'll just see.
Yeah, please stop share and then uh, do it again, sir.
Yeah, I've stopped it.
Okay, it is not. Yes. Now reshare again, sir.
Give me just a second. I'm so sorry.
No, no issue, sir. Some technical glitches are bound to happen.
Am I there? No.
Yeah, you are there, but sir, you can share your presentation to the screen share mode.
Okay
Yes, sir.
now?
Yeah, you can put on the sir
Yeah.
full screen mode.
Yeah, I've turned it to full screen mode.
Yes, sir. It is visible to everyone. Yeah. Okay. Thank you.
Yeah, first of all, as I said, my gratitude to the president, the secretary, the joint secretary, and the treasurer of IDA Hisar branch, and all the office bearers of the branch. My faculty colleagues were here, delegates who are attending this, and one and all here. As I said, I am going to deal with the topic on emergencies in routine dental practice. What is an emergency? The best way to describe it is to call it an unexpected and usually dangerous situation that calls for immediate action. So that explains it all that first of all, it is unexpected. Second, you need to act immediately. Such is the importance of this topic that so many books have been written on this topic, as you can see here. And all these books describe all the various conditions, the medical conditions that can present as emergencies in routine practice. But as all of us know, while reading these books, it becomes difficult to plan yourself to meet these emergencies when they occur in practical. I mean, we cannot go through and treat a medical condition like an MD physician would do. We are not MD physicians. Neither is the scope of this presentation to make MD physicians out of all of us here. What I have seen in the last around 40 to 45 years of my practice is that you need to have a very small setup and a small set of understandings to deal with these when they occur. Just on a lighter note here, when we attended the FDI 2014 in New Delhi, I happened to be the chairperson of none other than Malamed, who was talking on medical emergencies there and local anesthesia when he came here. So that was a pleasure of mine and my students who are there with me. As I said, medical emergencies can occur in a dental practice, though the frequency is not very high, but it's not very small too. On an average, as you can see, a general practitioner will experience one medical emergencies at least once every 2 years. So that is a rough frequency of some a study, and various studies give different things. And as the time goes by, see, this study was published in 2020. With increasing years, it has become slightly more frequent, and we all know that the patient expects the best out of you. So you cannot be less prepared and say that, see, I am not a physician, so I'm not the one who's going to deal with an emergency. So that's the reason why be prepared for emergencies. They won't warn you or give you time enough to prepare yourself to deal with them at that time. How do we prepare ourselves? These are certain basic steps that go, in terms of preparation, so that when an emergency occurs, you are ready. First of all, every patient needs to be assessed in terms of medical history. You must know whether the patient is a hypertensive, is a diabetic, has had a heart attack previously. I'll just put it in small terms so that it becomes easy for us to remember, and so and so. And patient, whether the patient has had food before coming, what kind of medicines the patient is having, all these things have a bearing. As soon as an emergency occurs, all these things come into your mind and you are better prepared to deal with it. And that is the reason why these things are important when we deal with an emergency. And that prepares us in terms of a minimum competence and the minimum amount of experience and equipment that we need to have while dealing with these emergencies. Before we deal with emergencies, let me tell you that you need to do a small assessment of every patient before you start a dental treatment. And this doesn't take time, it takes less than half a minute. The reason, you are better prepared when you deal with it. We all know about the vital statistics. I'll just add a bit of them. So we have C, we have T, we have P, R, and BP. What are these? C stands for consciousness. Now, the patient who's sitting on a dental chair normally is fully conscious. But then you may have a patient whose level of consciousness dips before you start a treatment, or while you start a treatment, while you are doing a treatment, or just about after you have finished your treatment. So that is when you need to know about how to evaluate consciousness. You cannot just say chakkar aa gaya, or you cannot just say the patient became unconscious. You need to evaluate. One of the simplest way is what we call as the AVPU scale. There are more elaborate scales like Glasgow Coma scale, etc., but those are used in hospital settings. For our practical purposes, the AVPU scale does suffice. A is when the patient is totally alert. V is when the patient responds to verbal stimuli. You're asking the patient something and the patient is responding. Below that is P, when the patient is responding only to painful stimuli. You pinch the ear lobule, you pinch under the nose, and then only the patient responds. And U stands for totally unresponsive. If you evaluate this, you may be able to understand where the patient's consciousness is. For us as maxillofacial surgeons, it's all the more important because we need to know whether there is a head injury component along with whatever injury the patient has come or not. But even in a routine dental practice, 99.99 patients will be in the A stage. But if there is a drop, you need to rapidly evaluate what is happening here. Next is temperature. We all know that the temperature is usually taken in the axilla, or these days with zero touch thermometers, we can have the temperature readings from within the auditory canal, the oral cavity. Forehead is not a very favorite site these days. Rectal is used in very small infants and other people who are not responsive. So that is something that we don't do. But these are the normal ranges of temperature. Whenever there is a drop or an increase in temperature, we need to know what is the temperature. Pulses are measured various ways, but the best way today is to have a pulse oximeter with you. It doesn't cost us much. But instead of trying to palpate a pulse, if you have a pulse oximeter, it gives us a better assessment of it. R stands for respiration. These are the common respiratory rates. The adult is in the range of 12 to 20, and the others increase with decreasing age. So that also is something that all of us should remember. And ultimately, BP. Fortunately for us, today we have easy control over measurement of blood pressure instead of mercury thermometers and something. But then today, still today, the mercury manometer is said to be the gold standard. But then since mercury is not uh, safe, we no more have those manometers available. So we have these digital manometers which can record on the brachial as well as the wrist. Whatever you have, three, four readings or five readings, give you an idea. It may not be exactly what the blood pressure is, but then give us an idea as to whether there is hypotension or hypertension occurring in this patient or not. So, having understood what are the vital parameters, there are certain additional things which we need to note. One thing which you can see immediately is the lip color, because the patient is sitting in front of you, the lips are exposed to you. The conjunctiva, when you slightly evert the lower eyelid, you can see the color in the conjunctiva, whether it is pale, whether it is cyanosed or whatever. So you can have a look at the conjunctiva. The skin is not a very reliable thing. The nail beds, of course, show us the color. What is the posture of the patient, the gait of the patient. This is one reason why in my clinic I always make a practice of telling my patients to remove lipsticks and nail polishes before coming into the clinic. Because if at all there is an emergency occurring, these are areas which may not be easily visible. There is a small anecdote here. Very recently, just less than a month back, an emergency occurred in a hospital setup, and instead of doctors, they had to call a beautician to come and remove the nail polish of a patient because none of the nails were allowing them to record the pulse oximetry. So that should not occur in your clinic. So that's an important thing that should be. Let us see some emergencies. Now, whenever a book or a lecture on emergencies is held, we often see that either the lecturer or the speaker or the book describes emergencies in terms of their diagnosis. There's a list of medical conditions. They describe one by one. We have read all of them in our medicine books or in our medicine classes previously. But then that is not the format in which things will be ready for us when an emergency occurs. What I feel is that we should know emergencies in terms of their symptoms and signs rather than the label of diagnosis. So that is why I say they don't come with a label of diagnosis. They express themselves as symptoms and signs. So from that point of view, I can divide emergencies that occur into systemic and regional. Most of the medical emergencies we are dealing with happen in the systemic side. Very few occur in the regional. I may not be covering that here. These are some problems in the form of which emergencies can occur in the clinic. As you see here, very few of them are in terms of the diagnosis of the condition. Most of them are in terms of the symptoms that the patient will come up with or the sign the patient will come up with when presenting with the medical emergencies. Most common, obviously, is a fainting. Second is a sudden chest pain occurring in your clinic. See, a patient who is having chest pain all through, you may not, in any case, take him up for treatment before the patient is screened by a physician. I'm so sorry, or an appropriate surgeon or a doctor. What we are more concerned with is the patient seems to be totally normal. You are just about to begin with the treatment, or you've just begun with the treatment. You're in the process of treating the patient, or you've just finished with the treatment, and suddenly the patient comes up with chest pain. Now, that is a medical emergency. So, I would call it sudden chest pain, sudden breathlessness, sudden rashes, sudden vomiting, sudden abdominal pain, sudden seizures. The only things which have come here as proper diagnosis are stroke and cardiac arrest. They are not symptoms. They are actual conditions. They are the symptom and they are the conditions. We'll deal with them later when we come here. The most common, as I said, is fainting or loss of consciousness. Patient has fainted. It's not always syncope. That's the reason why we need to be prepared with this. These are certain conditions where fainting occurs. The simplest one, obviously, is vasovagal syncope, but it can be a vascular condition like orthostatic hypertension. Even epilepsy and strokes cause fainting. Cardiac conditions causing cardiac syncope, and psychogenic attacks. In the dental clinics, it is often the fear associated with the procedure and whatever they see in the clinic that causes fainting. What do you consider when assessing the patient with? See, we may take time in reading these things, we may take time in understanding these things, but when we actually apply it to the situation, it shouldn't take time. That's why we should be prepared. If you had taken a proper history before starting the treatment, you would know when was the last food taken, what are the pre-existing medical conditions in that particular patient, what medications the patient is already on. So those things will already make a mental picture in your mind as to why the fainting has occurred, what prodromes have occurred here, whether the patient had headache before coming in, whether the patient had a seizure before you started with it, etc. As I said, fainting is a loss of consciousness. So this is the AVPU scale that you need to use at that time. I'm not going to describe the Glasgow Coma scale because that may not be the appropriate one in a dental clinic setup. What do you do? The first thing you do is lower the chair to near horizontal position if you are not already treating the patient in the near horizontal position. Reason? Improve blood supply with glucose and oxygen towards the brain. Allow fresh air. Don't allow people to crowd around you. It is best to have oxygen in your clinics. These days, we get small oxygen canisters, which are the best things to use in an emergency. Oxygen is almost a ubiquitous treatment material for all emergencies. Okay, so it is best to have oxygen. You have these small ceasefire sized small canisters which are available for not much in from Amazon and other Flipkart and other of these sites. It is not absolutely necessary that you should have a big oxygen apparatus in the clinic. Administer oxygen immediately, loosen clothing if they are tight, keep a visual on the vital signs. Best to use a pulse oximeter, as I said. Use a strong smelling substance. Now, this is something that previously every clinic used to have liquor ammonia. These days, we don't use it at all. That the sole purpose was to have a strong smelling substance which can stimulate the person to become conscious. Eugenol itself is quite strong. Every clinic has it. So a small cotton pledget with eugenol can be, shown under the nose near the nostril to arouse the patient out. Do not try to feed water or anything. It is very common for, if a person has fainted on the road, most of the, standing people around the patient say, isko pani pilao, isko pani pilao. That is the worst thing you can do. When the patient is not fully conscious, anything which is, introduced into the mouth can enter the respiratory tract. That is what we call as aspiration and cause aspiration pneumonia and even death. So never do that. Abandon or defer your clinical procedure. And the common syncope, the vasovagal syncope, is momentary. So within a couple of minutes or so, the patient usually starts feeling conscious and slowly comes back to fully conscious level. So once the patient has become fully conscious, even if the patient insists, okay, doctor, now you go ahead with your procedure, don't do that. Refer the patient to a physician because we are not the qualified people to know why this fainting has occurred if it has not occurred because of fear. Even if the patient feels that it was because of fear, in order to be sure, it is always best to refer the patient to a physician who can assess the patient better and tell us that, okay, this was only vasovagal, you can go ahead with it. So then accordingly, you can go ahead with this treatment. Second important symptom that may comprise a medical emergency in your practice is sudden chest pain. Patient is there. Patient was not having chest pain when the patient was in your clinic, but suddenly the patient has started developing chest pain. These are the common causes of sudden chest pain. Causes of chest pain are many. It's a list of around 25 to 30 entities. But sudden chest pain, where the patient is normal, but then suddenly the patient is having chest pain. Angina pectoris is the most prominent one. And surprisingly enough, even more frequent than myocardial infarction is hyperventilation. The patient has been breathing very heavily, probably because of fear, probably because the patient has come up 2 or 3 flights of stairs, probably because the patient is breathless because of anything, and the patient hyperventilates. That also can cause chest pain. Myocardial infarction, of course. Cervical spondylosis is a surprising element because why? Because the cervical outflow of the sensory nerves there supply the chest wall and the cardiac muscles as well. So cervical spondylosis itself can cause or mimic angina pectoris. So you need to be very, wary, and this is where the physician comes in. And ultimately, gastroesophageal reflux. This also can cause chest pain, mimicking angina pectoris and such things. So these are the common causes of sudden chest pain. Regardless of what the cause is, we are not treating physicians here. We are not going to treat the basic condition. What is our role? Our role is to recognize, settle the patient down, bring the patient out of that particular condition for the moment so that the patient goes to a physician to get proper treatment done later. This is what we do. Make the patient lie supine again, administer oxygen. As I said, oxygen is something ubiquitous, so one must have it. Try to detect the possible cause. You may not be able to do that. Everyone should have diclofenac sodium in the form of an injection or in the form of a dispersible tablet in practice there. If you are already aware that the patient is with a history of angina, then sublingual nitroglycerin may be a useful one, but not for every patient. You cannot assume that this is angina and give NTG. Call for assistance or ambulance. Do not continue your procedure. Refer the patient. Do not give stimulant beverages. Usually, after a chest pain or after angina, after you even when you know that this probably is a myocardial infarction case, patients are fed with coffee and such other stimulant drinks in order to try and raise their awareness and such things. That is very dangerous. Stimulant beverages can precipitate a second attack. So never do that. Sudden breathlessness. After chest pain, this one is the most frequent one with which you can, be encountered in your clinic, of course. Again, hyperventilation here. Bronchospasm due to bronchial asthma, it may be allergic, cardiac asthma in a patient. Patients who have COPD, obstructive pulmonary disease or tuberculosis. One worst thing is foreign bodies. It is very common for dental patients to have aspirations of appliances, of instruments, of materials, and such things. So that is something that we need to be aware about. Trauma, definitely. Edema, anywhere in the airway, lingual, pharyngeal, laryngeal, and pulmonary are common causes of breathlessness. And vasovagal episode is also sometimes associated with breathlessness. So one needs to think of the common ones immediately and then act. Surprisingly and fortunately for us, most of these conditions are treated in a very common way for tiding over the emergency and then referred. What do we do? Ensure that the airway is clear. Administer oxygen once again here. If the patient is already a nebulizer user, use it there. Otherwise, steroids play a very good role. And we all know that adrenaline is a bronchodilator. 1 in 1,000 adrenaline is something that we don't have in our clinics. What we have is 1 in 2 lakhs, 1 in 80,000, 1 in 1 lakh, etc. That may not help here. What we require is 1 in 1,000. So that is an important medication to have in your cabinet as an emergency drug. Stop your procedure, refer once the patient's breathlessness has slightly decreased. Sudden stomachache. What do we see? These are the various conditions that can cause sudden stomachache depending upon the sites of the abdomen. We need not remember this table here. This is only for the academic part of it. For us, practically, sudden stomachache may be caused by anxiety, some medication that the patient may have taken, something that the patient may have eaten that has caused this, gastritis very commonly, and GI tract infections, whether in the intestines or the stomach, the duodenum, the esophagus, all these things can cause these things. What do we do? The simplest and best remedy that we can do is administer antacid to the patient. I commonly have these antacid suspensions in my clinic. I literally feed half a bottle of this to an adult patient. Antispasmodics like meftal and such other things can be kept in your clinic, but then that is something that we don't normally. But even antacid itself plays a big role when faced with a stomachache patient. Diclofenac sodium IV, not oral. Antiemetics if the patient is having nausea and vomiting along with it. Abandon the dental procedure and then refer the patient to. At least the immediate problem of stomach ache is slightly relieved and the patient is in a condition to go to a doctor to get appropriate treatment done. That is the role of an emergency practitioner. Sudden rashes coming up. Your patient is on your chair and suddenly there is a rash. Rashes have come up, or generalized swelling may come up in the patient, or the patient may suddenly get breathless. You need to think about allergy in these patients. What is common in our clinic? Allergy to lignocaine. Though it is extremely rare, I have yet to see in my 45 years of practice, I've yet to see a patient with true lignocaine allergy. Many patients have been telling me that I'm allergic to it. So the best way is to be sure by doing an allergy test. The allergy test is done by injecting a very small amount, 0.2 ml, just under the skin. So you pinch up the skin and administer. Mark the site with a circle, note the time. So what is our test? Wait for approximately 30 minutes. If nothing occurs, no erythema occurs, no rashes come up, no swelling comes up there for 30 minutes, the patient is usually not allergic to lignocaine. There is a small catch in this. One exposure to allergen may not give any symptom. The second one can give a symptom because the patient is already sensitized to that particular allergen. So, what I practice is, if at all I feel that an allergy test is needed in the patient, I call the patient the next day to a repeat allergy test. If the patient is truly allergic and has not shown it positive in the first time, the second time may be seen here. But one has to see that a repeat or a sensitized allergy test may cause an extreme exposure, extreme, exhibition of allergy. So one needs to be really prepared. If there is breathlessness, if there is anything of it is best to do it in a hospital setup where oxygen or immediate resuscitation measures are present. Doctors are present to take care of it. So what we do is we do it in an emergency room there in the hospital. If I have a patient in my clinic, I usually refer the patient to a physician to get the allergy test done, or I would go along with the patient to do an allergy test in the presence of somebody who can take care if something occurs with the patient. What do we do if we know that an allergy test has occurred? Oxygen, number one, adrenaline, and a steroid like hydrocortisone or dexamethasone. So I keep dexamethasone, adrenaline, and oxygen. Even that much is good enough in your practice. One need not have a huge repertoire of emergency medication. You yourself will start getting confused as to what to use and what. These are certain things that are minimally required. This is the minimum competence I expect everyone to have when dealing with an emergency. The next one is a sudden seizure occurring in a patient. The patient is on your dental chair or is about to walk into your dental chair or is about to walk out of your dental chair, and the patient suddenly has a fit, a seizure, a convulsion, or a fainting attack. It may be a seizure related one. These are usually epileptic, drug reactions, substance abuse, meningitis patients, high fever patients. Obviously, those other conditions, we don't take them up. If they are already having high fever, it is best not to do a dental treatment in that patient till that particular condition is taken care of. Anxiety is one big cause of seizures, but then we take epilepsy as the solid example of seizures occurring in a patient. What do we do with that patient? Protect the patient first. If the patient is having a seizure on your dental chair, don't tell the patient to get up from the dental chair. Let the patient lie down in the dental chair in a secure position. If the patient is walking in towards the dental chair, pull him and make him lie on the dental chair. And the same, when the patient has just got up from your dental chair and is about to have a seizure, make the patient lie down on your dental chair again. so the patient is protected, or the patient may fall down and hurt. Make use of a mouth prop or a plastic airway inserted between the teeth and the tongue so that the patient doesn't bite his or her tongue or bite your finger if it is within the patient's mouth. Stop your procedures. Now, midazolam is not something that every dentist can have in the clinic. It's a protected drug, it's a restricted drug. But we can get midazolam in the form of liquid oral suspensions. These are called as buccal midazolam. It is available in India too. You can just pour in about 4 mg or 5 mg worth of midazolam into the patient and tell him or her to drink it. It relaxes. Diazepam is something that used to be available in our college days and in the early days of my practice. But these days, diazepam is not something which you give, which you get very easily. So a related benzodiazepine is midazolam. So give it to the patient, makes the patient relax. The immediate seizure problem is taken care of, and then you can refer the patient to an appropriate doctor who can treat the basic condition which has caused that seizure. One small note, if at all, I don't know, mouth prop is almost ubiquitously present in everybody's clinic. So the safest way is to have a mouth prop with a chain, so that part of the mouth prop set is hanging out of the mouth of the patient. For those who have airways, the airway is inserted inverted, the tip pointing up, and then turned through 180 degrees once the tip is in the throat of the patient. That is something that we may not practice in our routine dental clinics because an alert or a fully conscious patient may not tolerate an airway. A mouth prop, almost everybody does. This is something that one needs to know. A stroke. What is stroke? Stroke is just a brain attack, just like a heart attack. If blood supply to the brain is reduced, it causes stroke. What reduces blood supply? It can be hemorrhage inside the head, or it can be a clot that has gone and blocked a vessel. So there are two types of strokes mainly: ischemic and hemorrhagic. So if it is because of a clot blocking blood from flowing into the brain, it is ischemic. If it is because of a head injury and a hemorrhage occurring, or a hemorrhage occurring because of hypertension or whatever, that is a hemorrhagic. Now, regardless of all these causes, it is important that we recognize stroke. Now, this is something that was published in the Tribune for the common man, and that we should consider ourselves as common men in terms of dealing with medical emergencies. So these are certain things that you should be almost always aware about. If you suddenly see that the patient has just got up from the chair and is not very balanced in walking, very momentary, it can be because of orthostatic hypotension or vasovagal attacks there. But then if it continues, that the patient is feeling dizzy or not walking in a very proper way, is stepping left and right while walking out, or if the eyes have started becoming drooping, or if you see asymmetry in the face because of facial paralysis on one side, arms may be asymmetric and may not work fully. But the best one is to note the speech of the patient. Sudden slurring of the speech, as if the patient has just had a drink or two. These are symptoms that may suggest that this patient is about to have a full-fledged stroke. And that is why time is very important. The first half an hour is the best time the patient can recover 100%. Though it is said that it is the golden hour, but I wouldn't even put it as golden hour. I will put it as the first half an hour when the patient should receive medical treatment so that the stroke gets reversed. So that is why recognizing a stroke in time is a favor done on the patient. Timely referral and timely treatment are the keys to 100% recovery. Treatment started within 3 hours have shown almost complete recovery in the publication. But remember, first half an hour to first 1 hour is very, very important here. Now, this is something that scares everybody: a cardiac arrest. As I said, this is a symptom, this is a disease, this is everything, this is the diagnosis. Because there is nothing else. Cardiac arrest means cardiac arrest, that's all. What is cardiac arrest? To put it very, very simply, cardiac arrest is a condition where you are not able to appreciate the heartbeats. So if you put your hand to the chest wall, you're not able to see a heartbeat. If you put a stethoscope to the chest, you're not able to hear a heartbeat. So why can this occur? This can occur because of two reasons. One, the heart has actually stopped beating. It has stopped functioning. That is a cardiac arrest. That is called as asystole. There is no beating of it. Asystole. The other one is when fibrillation occurs. There is beating, but then it is of such a high frequency that you are not able to, and low volume, you are not able to appreciate the heartbeat in the proper way. So both these conditions bring about what is called as cardiac arrest. Both these conditions will result in no blood pumped out to the body. So obviously, if the body doesn't get blood, two things occur. One, the brain doesn't get blood, so one loses consciousness. Two, the lungs don't receive blood to oxygenate them. So indirectly, again, that also leads to deoxygenated blood remaining in your system and cells not getting enough oxygen. And that is why this is a cycle: cardiac arrest, pulmonary arrest, brain death. Brain death, pulmonary arrest, cardiac arrest. Pulmonary arrest starting first, cardiac arrest, and then brain death. So either ways, in whatever starts it, it becomes a common thing. That is where we need to cut in before these things occur. A cardiac arrest may have occurred, but we have a very short span of time, though still we have a span of time to intervene so that nothing occurs, nothing untoward occurs. That is where we, this is how to recognize cardiac arrest: absent pulse, no heart sound, and a fibrillation or flat line in ECG. Obviously, we do not do an ECG in our clinic. What we can do, put in a pulse oximeter. You will not see a proper pulse. Either you will see a very fizzy wave or you will see a flat line in the pulse oximeter itself. So that is when you need to know that this is cardiac arrest. We have very little time left to resuscitate the patient. What happens? Why do we need to be prepared? Now, these are certain examples. There are many more. But then see here, common men. 2020, a passenger collapsed at Kolkata airport. Sub-Inspector Partho Bose rushed to the passenger, found him unconscious, not breathing, immediately gave CPR, cardiopulmonary resuscitation, to the passenger, and the passenger became all right. Why? Because he was prepared to do a CPR. So he's not a doctor, but then he's been trained. So that is the reason why all of us need to be trained in giving CPR. Another example, just in 2022, a doctor present in an aeroplane could resuscitate and revive a patient who became unconscious and had cardiac arrest mid-flight. Now, see what the doctor says. He says anyone could have done this, but it's not so. And not anyone. Only those people who are already, aware of how to do a CPR can do it. And the patient may feel that this is something that I have not come across because it doesn't happen to me. That's not true. Again, awareness is important in this case. 23, a Rajasthan cop revived a person on the road in a mela. Why? Because that person was on duty and acted swiftly. He was a policeman, a deputy SP, Rajendra Meena, who could save the life of a patient because he knew how to do a CPR. Very, very recently, just in February 2026, this boy was a oral surgery PG from a college in Vadodara who had been trained as part of the oral surgery curriculum, was trained in giving CPR. So again, mid-flight, there was an emergency. The doctor called in. Doctor was about to land at Lucknow, but Dr. Aditya could successfully save the patient's life in mid-air. So this is something that has just occurred very, very recently. Why I'm showing all these examples? These are examples of common people who are not equipped with anything high. When you're traveling, you don't carry something very high. But it makes a big, big, big difference for the person who has undergone cardiac arrest. So all of us, again, I'm overstressing this point that all of us need to be prepared to give CPR. That is why the Indian Resuscitation Council invites people to come and train themselves. Even our former Vice President Venkaya Naidu said that this is something that everyone should be trained for. That time, look at that. For every 1 lakh person, India sees 4,500 cases of cardiac arrest. Well, USA only has 60 to 110. So that is the importance. But we give it less. That is why we need to train ourselves in CPR. It is beyond the scope of my presentation here to train you all in CPR. One must find out who gives you training very close to you and get it done. This is something that you may see in airports and public places very commonly these days. This is called an automated defibrillator, which is present. It is very easy to operate. Even a non-trained, non-medico person can easily operate it. Those instructions are given in that you need to break open the glass and immediately start using it. And that may be a difference between life or death for that particular patient. Sudden fever occurring in your clinic. No, I'm not talking about a patient who has come in with fever. A patient who has come in with fever, refuse treatment. Tell the patient you come back after your fever is totally gone. Don't underestimate fevers. Don't think, okay, it doesn't matter. It is just common cold. What will happen if I do a simple filling? Don't do that. Everything we use in our clinics can enter the respiratory tract as aerosols, can cause additional problems to the patient. A patient suffering from even a simple common cold has momentary immune deficiency. So we should not, or we can get exposed to that condition and ourselves fall sick. Refuse the patient treatment. Doesn't matter if the patient has to come back after a week's time or so when the patient is fine. Anyway, what I'm talking about here is sudden fever occurring in a patient. This may be because of infections underneath, maybe because the patient has just walked in the very bright summer sun, heat exposure, or the patient works in front of a furnace or something of that sort. Side effects of some medicines, neoplasm, drug abuse, even oral infections cause fever. So, what do? Measure the temperature. Give paracetamol, which is one of the safest. Very, very, very few people are sensitive or hypersensitive or allergic to paracetamol. So, very safe drug you can give. And best is to refer to the patient. But we are not the people. A fever is not something that can bring about some grave complication in your clinic. So, even if you don't give paracetamol, it's okay. Refer the patient. Don't continue with your treatment so that the fever is taken care of. Sudden vomiting. Patient is sitting on your chair, the patient is walking in, or patient is walking out, and suddenly the patient vomits. Now that's a medical condition that we need to be worried about. Common causes: foodborne illness, indigestion, etc., etc. For us, gagging and nausea while doing dental treatment can be followed by vomiting. So that is something that we need to be aware about. Gag reflexes in the patient. Patient has ingested something that you have just put into the patient's mouth. I have had a student of mine who wanted to get an upper third molar extracted by me. I just finished off with the extraction. The student immediately closed her mouth and she swallowed that too. So it's good that she swallowed that too, but then it was immediately followed up with vomiting and the tooth came out in the vomiters. So good for me again, but then these are certain things that you need to be aware about. How do you assess? You assess the color of the vomiters, how much is the vomiters, what kind of vomiting, was it projectile that the vomiters has come out at a high speed, whether there was a history. If you had taken a proper history, you would know about these things. So these things are pointers that you should keep in mind if the patient has this symptom. Possible problems that you need to manage: position the patient so that the vomiters doesn't enter the respiratory tract. So what is the best position? Side posture, even on your dental chair. Turn the patient 90 degrees to either the left or the right side so that even if the patient vomits further, the vomiters comes out. Let it dirty your clinic, it doesn't matter. But let it not go into the respiratory tract of the patient, because the patient who's violently vomiting or vomiting is not in full control. So that is the time when the patient can aspirate or take it into the respiratory tract, which may become fatal for you. Assist in clearance. Rapidly suck with intermittent sucking. Don't put the suction tube into the patient's throat. Intermittently suck out whatever you see in the mouth and pinch out whatever is in the nose so that the patient is better in a better position. And once the patient has stopped vomiting, at that time, give antacid, like what I showed you. The liquid antacids work well in patients who have stomach ache, who have vomited. It immediately brings down the symptoms of the patient. Defer the procedure, refer the patient to a proper, and instruct on timing and quantity of food the next time when you call the patient. Now, this is not strictly a medical emergency, but then this is something that is in the gray zone which we need to be worried about. Drug interactions occur. They occur quite frequently. Unfortunately, no statistics are very easily available on drug interactions. But this is an old reference where I found that 2.2 million severe adverse drug interactions occur in every year in US. It is the fourth leading cause of death in the US. The Indian scenario, it may be same, it may be more, because here there are so many reasons why a drug interaction or interactions occur. Medicine to medicine, food to medicine, alternate therapies to medicines which you may give, and so many other things that the patient may not be able to tell you that I'm taking this. So this is what is the diagram which shows drug with food, with herbals that the patient may be taking, diet with the patient may be taking. All these things are important. Fortunately for us, there are so many books available on drug interactions, but obviously, again, a book is not a very standard resource to be kept in the clinic for the time at which the emergency is occurring. What is better? These days we have mobile apps available. See here. What I found as the best one is Medscape, what you find here. You can download it very easily. These things, if you already know in the during the history what all drugs the patient is already on, including herbals, alternate therapies, and all those things, and what all drugs are you going to prescribe, you can just put that list into that particular app, and the app will show what are the possible interactions, whether they are severe interactions, moderate interactions, mild interactions. I always make it a point to do this whenever I see a patient who's already on several drugs. Even if I know there was a drug interaction previously or there is no chance of a drug interaction, it is always safe to evaluate this before you start with the patient. This is something that I would like to impress upon everybody here. So till now, what we have seen is all those things that have occurred with the patient. But a medical emergency can strike you too. You're in the clinic treating the patient and you are having a medical emergency. The patient is not somebody who's going to take care of you. You have to take care of yourself at that time. Only one note that I need to add here is I have not listed pregnancy related complications or pregnancy related emergencies that can occur in the clinic. The worst one is a labor pain starting in your clinic on your dental chair. So that is the reason why you need to be aware. And that is why follow those golden rules. Don't treat patients in the first trimester. Don't treat patients in the last trimester again. Because if you do that, you are more likely to encounter problems with pregnancy. Treat patients in the mid trimester with appropriate consent, with appropriate information to the treating gynecologist so that in case something occurs, the gynecologist is immediately available to take care. Because that is not something you can do like Amir Khan did. No, we may not be able to play that role in our clinic here. So one has to be cautious about that. So again, coming back here, if you start fainting, stop your treatment procedure. Don't become brave. Doesn't matter. I'll finish off this filling and then see what happens. Don't do that. Stop the treatment procedure. Call for assistance. Explain to the patient, see, I'm feeling giddy. I don't want to continue with your treatment right now. I'll do it later. Second thing which can occur is the patient may bite you. Where you're treating, because of any reason, the patient may suddenly bite your finger or your thumb, whichever is inside. That also is a medical emergency that you are going to face. Everything that are related to bites, related to HIV and all those infections, you need to have a proper prophylaxis against exposure to those things. Remember those things. I've not put it here because it's not a true medical emergency. So how do we prepare ourselves in terms of infrastructure? One needs to have an emergency kit. As I said, the most common ones you should have is one steroid, either hydrocortisone or dexamethasone, adrenaline 1 in 1000, Avel, chlorpheniramine maleate, or any anti-allergic. Even if you don't have it, it doesn't matter. As I said, midazolam for epileptic seizures and such things. Theophylline, etophylline, commonly available as deriphylline, is a bronchodilator. But then if you have adrenaline, you don't need this. Diclofenac sodium, either in the form of a dispersible tablet or an injectable. Hemostatic agents for sudden bleeding occurring. And many of these small items. It's not important that we have everything here. Obviously, everybody cannot have a glucometer and all these things in the clinic, but suffices to have a pulse oximeter and oxygen canister. Other things usually are there, or the patient can avail of these things when the patient goes to a proper physician for getting care of that particular emergency. So that's one thing. And the second thing is one must be aware of who are the doctors available close by. If you're not practicing, it is best to practice in a setup where it is a hospital, a multi-specialty hospital where you are there and other specialties are already also present in the hospital. Or if you have a standalone dental clinic, you should have a directory where a physician, a surgeon, a gynecologist, all these common people around you, their numbers with immediate contact possibility. And you must have already talked with them previously that, see, I bank upon you all when an emergency occurs, so that somebody responds. And it is not one physician. You should have a small list of 2, 3 physicians, so that if one is not available, the other is there, and the patient can go to that particular doctor to get evaluation for the emergency that has occurred. A surgeon, a gynecologist, depending upon what kind of emergency has occurred. So that directory is something that will suddenly come in your mind when you require it. And that time you cannot sit down and start preparing a directory or start hunting down where whose number is what and all those things. So that is something that you should have under your table glass or somewhere stuck to your wall where you can immediately refer to, or entered in your mobile in a very prominent way where you can make a ring immediately. So that is something that I need to tell you all. Thanks a lot for the kind hearing, and really expressing my pleasure again to be with all of you. Thank you, Dr. Bhuvan. Thank you, all the office bearers of the association, for having me here. And I hope in this short span of time, I was able to do something in terms of getting people prepared to deal with emergencies in the dental clinic. Thanks a lot again. Anybody has any question? Definitely. I'll be all too glad to hear you.
Thank you so much, sir. It was a really nice presentation. Thank you so much, sir. After so many years, I'm seeing you.
Thanks a lot. It's a pleasure. It's my pleasure.
Thank you so much, sir.
Hello, how are you? And thanks a
I'm
lot.
good. आप
Long,
कैसे
long,
हैं?
long. बिल्कुल बढ़िया. Very, very long time. You must come down.
हाँ,
अगर ऐसे.
मैम कैसी हैं?
Ma'am is fine, beta.
डू यू रिमेम्बर आपने मेरी सर्जरी की थी?
So sweet.
So
Thank you.
there are few doubts, sir.
Yeah,
Sure.
yeah, please. Everyone can now. I'll make.
This is
You can unmute yourself.
this is Rajat Gupta from Nirvana.
Hi,
It's a
Rajat.
it's a city near a small city near Hisar, sir.
Yeah, I'm aware, beta. I've come to that side. As I said, I've been driving a lot previously when I was in DAV Dental College. So I'm aware of Nirvana. Yeah, please go ahead.
What are the upper limits for blood pressure, sugar, and INR, under which we
Well,
can treat the patient?
right.
Upper limits
Right.
for
That's
BP, sugar, and PTI INR.
absolutely. That's a very, very, very relevant question. In practical terms, a blood pressure more than what we see is systolic, which is for the purpose of evaluating. Diastolic is also very, very important, but practically speaking, any systolic pressure above 200 millimeters of mercury or below 100 millimeters of mercury systolic, I mean below 80, sorry, and diastolic pressures below 60 mmHg or above somewhere around 150 to 160 mmHg, I wouldn't treat that patient till that patient visits a physician, gets evaluated at least, and gets a safety note from the physician. So,
What's the upper limit you told, sir? Upper limit
for the systolic for dental treatment, I would consider it as 200, persistently above 200. I take 3, 4 readings and it is persistently above 200 mmHg. I wouldn't treat that patient. Reason? The systolic pressure may go even beyond that when you are actually treating that patient. So that is there is nothing called as a safety limit. It is individualized. Everybody has an individual safety limit, but this is something like a pointer. So if I find that somebody's systolic BP is consistently above 200, I wouldn't treat that patient before the underlying problem is solved. And diastolic somewhere above 120, 130, I wouldn't treat that patient till the physician sees the patient, because diastolic again tells you about the basic vascular bed. So I wouldn't treat that patient. Coming to your next thing, INR. As you already know, we all know.
Sugar and INR, sir. Sugar and
Yeah.
INR.
So coming to INR, as we all know, INR is a ratio. Any INR above 2 to 2.5 is likely to bleed more than what we can handle. So the safety limit is a patient. Why is the INR is important to us? Because many of our patients may be taking anticoagulants because of their underlying cardiac conditions or whatever condition, or because the patient may have undergone angioplasty or a coronary bypass surgery or anything of that sort, or a valve replacement. All these things are associated with anticoagulants in the patient. Some patients may not know also. Some patients may not be aware that I need to say this, tell this to the doctor. So when these things occur, it becomes relevant for us. So that is why history is important. As I said, anybody having an INR more than 2.0, I refer back to the physician to try and see whether the physician can handle or bring the INR a little below 2.0, and we can do up to 2.0. Up to 2.0, I consider it safe here. Now, coming to blood sugar, lower limit is more important than upper limit. But still, I mean, if we see what is relevant to us is the glycemic control the patient is having. A blood sugar suddenly is more than 200 to 250. It may not be very important because it may be just a spike. But if it is consistently above that, what I tell my patients is to make readings and show me the next day or the next day, 2 or 3 days, and then take up. So practically speaking, why are we concerned about this? We are concerned about this not from the medical emergency point of view. We are concerned about this from the point of view of uh, attracting non-healing or infections in whatever surgical procedure we are doing. So anything above 200 mm, 200 mg per deciliter is something that we don't put implants in unless that thing is brought down consistently below 200 or any other such procedure. I would like to have it below 200 or maximum of 200 blood sugar in those patients here. So not something which is absolute again. Every patient has a very different thing. But then on an average, that this is what we normally see. If the patient is having a good glycemic control, I wouldn't mind doing it. But then in those patients who have something like an implant which is going to be there for a good number of years in the patient's tissues, we need to see that the sugar is well kept under control, not necessarily, absolutely to the normal limits. But for practical purposes, as I said again, anything below 200 is something which I easily accept.
So what? So
Yeah.
so what I understand, sir. So we can inject a patient with a BP 190 and 110.
Inject a patient in the sense?
If a patient has a BP of 190 by 110, can we go with the
LA with adrenaline, as a
LA?
rule, I keep only 1 and 2 lakhs in my clinic. But most of the cartridge systems have 1 in 1 lakh or 1 in 80,000. Now that is something dangerous. In an unknown diabetic patient or in an unknown labile hypertensive patient or labile angina patient, 1 in 80,000 can cause problems. So my best advice is don't keep 1 in 80,000 or 1 in 1,000, keep 1 in 2 lakhs with you. Because the amount of adrenaline that goes into a patient while injecting 1 in 2 lakhs is less than the amount of adrenaline that is endogenously released by even simple anxiety the patient may be undergoing while getting the dental treatment done. So that even that simple endogenous adrenaline release from the adrenal gland is more than what you are going to inject into the patient. So I would still consider it safe, even if you know that the patient is an angina patient or an ischemic heart disease patient. So very, very, very rarely do I use plain lignocaine in my practice. I use 1 in 2 lakhs almost ubiquitously. If we've found it, we've conducted an entire dissertation in our department there to evaluate what are the effects of using this, how much is, against a placebo, which was giving rise to more symptoms of adrenaline than 1 in 2 lakhs many times. So statistically, it was quite acceptable to use 1 in 2 lakhs as a standard one in such conditions. 190 by 110, blood sugar less than 200, INR less than 2.
Okay, sir. I have seen a few more conditions where the BP is falling and the pulse is about 2-3 times.
Both these things occur, though both these paradoxes occur. The patient has hypotension and bradycardia. Patient has hypotension and tachycardia. Patient has hypertension with bradycardia. These things, these paradoxes occur in patients because of several factors which are working inside. It may be vascular, it may be pulmonary, it may be cardiac, it may be neurogenic. We are not the people who are and experts in dealing with this situation. But when such a thing occurs, obviously, it is best to abandon treatment, send the patient to a proper cardiologist or a physician, get the things worked up properly, and then take up the patient for surgery.
What can we do on the chair, sir, when the patient is under hypotension and tachycardia? Can we do anything? Should we do anything?
See, per se, we are not authorized or we are not the qualified people to take up treating these conditions. We treat the basic symptom that may comprise the emergency at that time. If the patient has fainted, whatever fainting measures we undertake are good enough to bring the patient back till the patient can be shifted. If the patient has, a hot flush, make the patient relax, let it come down slowly, and then refer the patient. That is why these things are important, that you need to have numbers of ambulances and physicians, so that if that thing gets pulled on for beyond 5 minutes, you need to refer the patient immediately rather than trying to treat the patient. We are not qualified enough or ethically good enough to treat those conditions in our clinics.
That means oxygen is the only savior for us.
Oxygen, reassurance are the best things that we can do. And if the condition lasts beyond 5 minutes, best is to shift the patient out in a stretcher to an ambulance and to a nearby hospital. Because whatever is occurring inside may be beyond the purview of our treating capabilities. So it is risky to try and attempt to treat the basic condition. I never try to attempt to do it. Because we are not qualified, first of all, we may be under equipped to treat those conditions. So those conditions are best treated in an ICU rather than by yourself.
Okay, sir.
Very right, sir. Just to add on, sir, I have shared the photograph also, that for any elective dental extraction, the fasting should be 180 can be taken as a cutoff. It's by the recent study, Gath et al. And the RBS should be 234. And it should not be below 70 for patients on insulin or any other tightly controlled hypoglycemic.
Very true. Very true.
And,
these norms keep these norms keep getting updated as evidence supports it.
Yeah, it was because I also took one presentation, so I thought I'll share the recent one.
Thank you. That's lovely.
Should we go for HbA1c, sir? Should we rely more on HbA1c?
No, you cannot say whether you rely more on HbA1c or the spot value. Both these things are required. Both HbA1c as well as this. You cannot see the HbA1c tells in terms of your long-term glycemic control.
Very right.
Well, the spot assessment tells you about what is there at that time. So both these things together will guide you as to how you can go about. So in my, what needs to be done is you all have to make a list of blood tests that are required, minimum list of requirement in each kind of patient. For extraction, these are the minimum things that I require to prescribe. For an implant case, these are the minimum things, including vitamin D and such things that are, you have to do a retro thinking. If a failure has occurred, and if you list the causes of why that failure has occurred, you would be able to know what all things you should assess previously so that that failure does not occur. That is how you should. It's a retro thinking about those things.
Very right, sir. Anyone has any other question?
Sir, most of the time we are dealing with the hypotension, sir.
Very true.
Most of the time, hypotension is the main problem.
As I said, hypotension is the first thing that occurs when a vasovagal attack also occurs. So reassurance, oxygen, making the patient take a little bit of rest. If the patient is totally on an empty stomach and the patient is fully conscious, give glucose solution to the patient. Keep glucose powder in your clinic and immediately give glucose solution to the patient. Hello, Sachin. How are you?
Anji, good evening, sir.
Good evening.
So should we use adrenaline IM?
Adrenaline IM? For
Yes, sir.
as I said, don't try to treat the basic condition. Don't do that. Let the
Okay.
let the patient get reassured. If it lasts for more than 5 minutes, best is to shift. You give IM adrenaline, and if the blood pressure goes up beyond what you can treat in your clinic, then you are stuck. Or if the patient is a labile, in terms of adrenaline, I'm assuming you're talking about 1 in 1,000.
1 in 1,000, sir.
Yeah. So 1 in 1,000 is a dangerous drug if directly given. Even while giving 1 in 1,000 adrenaline, we would like to dilute it with saline or something of that sort. So
Yes, sir.
we don't give 1 in 1,000 directly, and that also in a very, very small quantity. It is better to be on the safer side rather than going beyond and facing another complication. In our
Sir,
set,
one question from my side also. Sir, how we can convince the patients to go for a triple H test for the procedures? Because whenever we say ki we have to taken for a triple H test, they show lots of resistance in the private clinic.
it is obviously for any test, the first thing that comes into mind of a patient is, why is the doctor getting so many tests done? Is the doctor having some understanding with the lab person or
Hmm,
something of
hmm,
that
hmm,
sort?
hmm.
Make the patient understand what can happen if you don't get it done. Try to point out those wrong things that can occur in a patient if this information is not available with you. So once the patient knows, yes, this information is not available, and if this has happened, then how would the patient doctor know that this is the condition? There is no time to test at that time then. So from that point, again, explain the patient in the reverse order. See, I am getting prepared for the worst. You are going out on the road. Would you like to go on the right side of the road, knowing that that can cause accident? You would go only on the left side. Why are you going on the left side? Because that is the norm. That is where accidents are less frequently occurring. Something of that sort. You need to explain that yes, I need this so that I'm better prepared. If something goes wrong, I know what has gone wrong, and I would be in a better position to treat you. So that is how you need to explain it to the patient.
Sir, should
That
we
is what I
always
do.
go
But still, after all this, if the patient is not willing to get it done, then politely you need to put your foot down and say, I need this. If I have to do your treatment, I need this.
Sir, should we always go for a bleeding test, bleeding profile in a hepatitis patient or a chronic alcoholic?
Absolutely. Absolutely.
Always.
Absolutely. Without fail. Wherever you suspect that the liver has possibly got affected, you need to evaluate the bleeding profile, because the liver is the first thing that goes wrong in a patient whose liver is not working right is this. That is something that you need to.
In chronic alcoholics also, sir.
Absolutely, because chronic alcoholics are more likely to have liver failure, whatever stage.
And if the patient is under treatment and under recovery, if a hepatic patient is under treatment for hepatitis, any type of hepatitis, and is recovering, do we still need the bleeding tests?
See, the first thing that one needs to know is, when you're writing down a test for a patient or an investigation for a patient, you need to tell the patient, what I would prefer is to have a normal report. What I want is a normal report, even if you have spent on it. And if a normal report comes, don't think, I have spent it for nothing, it is all normal. That is something that you want. So, better to be safe than sorry. So, better to have those tests, make the patient understand why I need these tests. Better to have them in your hand rather than repenting later, and you don't have time to do those tests later. So, wherever you feel that there is a possibility or there is the slightest of a chance that these things may be deranged, go for the test. Why are these tests available today? It's not those days when a doctor works on intuitions. Nobody can call himself or herself a good doctor just because you feel the pulse of a patient and you're able to make out everything on that patient. Those days are gone now. We need to have evidences, because the patient tomorrow can ask, why didn't you get it done? You are educated enough to have realized, I am a layman. You should have told me what is the importance of getting it. Get it done. If the patient is not willing to get it done, I would rather politely say, then I am sorry, I may not be able to treat you without this. Go ahead and get it done. Later, the patient can be impressed upon as to why you got it done.
Thank you, sir. Right.
Excuse me, sir.
Yes. Yes,
Sir,
Dr. Avi.
which markers you had told in allergy test to local anesthesia LA?
I didn't talk about markers here at all. I was just telling as to how an allergy test should needs to be conducted. There's a YouTube resource. There are several YouTube resources on it. I was showing one of them as to how to conduct an allergy test in a patient for anything. LA is one of them. Pinch up the in skin, put in zero point 0.2 ml of the solution for which you want to test it. Note the time, put a circle around it, watch out for symptoms occurring for 30 minutes at least before you ensure that it's okay. And call the patient back again the next day or the day next, so that you don't, have the chance of an increased sensitivity to allergies. I didn't talk about markers in this.
Yeah. Dr. Varun?
Yeah, good evening, sir.
Hello, Varun, how are you?
I'm fine, sir. Thank you very much. And what are the latest recommendation for this thing? If patient is taking anticoagulant, for how many days we have to stop anticoagulant before extraction?
See, this is a very tricky question. When you refer a patient to a physician, the physician always writes a big notes and says, stop it before this time, so many days before the, if it's an antiplatelet, so many days. If it is some other kind of anticoagulant, so many days. And you use lignocaine without adrenaline. It's a big list of things that you need to do. One practical pointer that the American Heart Association very clearly states is don't stop anticoagulants. If the INR is more than 2.0, I would rather refer the patient to a physician to evaluate and adjust the dose of anticoagulant so that it comes down to 2 or less than 2, and then do the patient rather than stopping that anticoagulant. To put it in a layman's way, stopping the anticoagulant may bring in the episode of that condition for which the anticoagulant is being given. That risk is more than the risk of small amount of extra bleeding that the patient may have. So reassure the patient if it is less than 2 or up to 2 INR 2.0 that you are likely to have twice the amount and twice the duration of bleeding than me if I'm not taking an anticoagulant. Doesn't matter, I'll take care of it. You can sit with a cotton plug in your mouth on my alternate dental chair or even in the waiting room or in the consulting room. I'll call you back again, change the cotton as many times as I note till that bleeding is comparatively less. If I am able to send back a patient who's not taking anticoagulant within 10 minutes, I would send you back after half an hour. What is the problem in that? So once that is said, the patient is reassured. It is better to have a little bit more bleeding than a patient having a thrombotic episode.
It means that if patient is on
I
anticoagulant,
don't stop anticoagulants at all.
no, that is fine. If then we have to get INR first, and then we have to do the
Absolutely.
procedure.
Whenever a patient is on anticoagulants, I always advise APDT and INR to that patient.
Very right.
Okay, sir. Thank you very much.
Most welcome, Vita.
So we had very nice interactive sessions, sir, by the number of questions, and
It's a topic which puts me also in the gray zone.
it is your modesty, sir, your greatness that you are telling like this. So now, sir, we all can wrap up and just a small token of appreciation from IDA Hisar, sir.
Thank you so much. Thanks a lot. Very valuable for me.
Yeah. So,
Sir,
it is.
just one request. We also want your physical.
Thank you.
Thank you so much.
Okay,
Thank you
thank
so much, sir.
Thanks a lot, Beta.
Okay, then thank you so much, all the participants, and we'll come up with a new topic next month or as the time permits. Till the time, please stay tuned and stay updated with IDA Hisar updates. And definitely, we are trying to get a speaker on CPR. So as it is finalized, we'll inform. Thank you so much, everyone.
Probably you could speak with your Red Cross people there to arrange a session with mannequins. Or a medical college can easily do that, the anesthesia department.
I'm in the process, sir, of arranging an anesthetist with the proper dummies and all the things. So let's
Absolutely.
see how it works out, and definitely we'll come up with that, sir, because it's a need of our everyone
Absolutely.
should. Yes.
Absolutely. Absolutely.
Thank you, sir. Thank you so much,
Thank you
and
so much. Thanks a lot. It was a great pleasure. Great pleasure to be
good
here.
night,
Thanks a lot,
everyone.
everybody. Good night.
Thank you, sir.